Welcome to our fifth and concluding digital Layla Lavan Ethics and Morality Salon. Thank you for tuning in. My name is Michaela V, and I'm the owner of Sidewalk Citizen and one of the curators. More than ever, I appreciate our moral obligation to note that in the spirit of respect, reciprocity, and truth, we honor and acknowledge Mokintis in the traditional Treaty 7 territory and oral practices of the Blackfoot Confederacy, Sisika, Kenai, Piikani, as well as the Nakota and Tsuut'ina nations. We acknowledge that this territory is home to the Métis Nation of Alberta Region 3 within the historical Northwest Métis homeland. Finally, we acknowledge all nations, Indigenous and non, who live, work, play, and help us steward this land, honor, and celebrate this territory. This sacred gathering place provides us with an opportunity to engage in and demonstrate leadership on reconciliation. This series is a co-production with the Calgary Institute for the Humanities at the University of Calgary through their excellent applied ethics program, and will focuses on some of the ethical issues that have emerged from the pandemic. We are truly fortunate to have enlisted an incredible lineup of speakers, and I would like to thank my fellow curators, Dr. Jim Ellis, Professor of English and Director of the Calgary Institute for the Humanities at the University of Calgary, Dr. Justin Weinhardt, psychologist and associate professor in organizational behavior and human resources at the Huskian School of Business at the University of Calgary, and award-winning journalist and moderator of this series, Christina Frangu. I would also like to thank Boulevard Noir, a local band who composed the beautiful music that accompanied the opening slideshow. When we started Tzafta and Layla Lavan's Salon series, we wish to provide a space for discussion, inviting people to sit together, share food, drinks, ideas, and time. Time, attentiveness, is a luxury that we are often careless with, both with our own and asking it from others. Simone Weil said that attention is the purest and rarest form of generosity. As life has slowed down and confronted us with abundance of time, sometimes more than we knew what to do with, allowing room for anxiety and dread, it was easier to find escape outlets to occupy the mind and distract it from reality. I am conscious of the generosity of our speakers, curators, and our audience who chose to engage in the series, and for the rare and precious gift of your time. Thank you for that. Born in Israel, as I am, Dr. Neria is an intellectual whom I followed for years and admired his work. Dr. Neria offers a unique, deeply humane, compassionate, and learned insight on coping with trauma and grief. The recent events that sparked international outrage with the brutal killing of George Floyd are pressing us to re-examine our civil and moral stance, the responsibility of who we chose to lead us, and the imperative to engage and confront the moral and ethical issues of injustice and inequality. We are honored to welcome Dr. Neria and our moderator, Tzafta alumni and friend, Christina Frangu. Christina Frangu is a writer and journalist in Calgary, Alberta, who specializes in writing about health, medicine, social issues. Her work has appeared in The Guardian, The Globe and Mail, Maclean's, Alberta Views, and Reader Digest, amongst many others. She writes about topics such as refugees, grief, loneliness, and public health. And with that, I would love to welcome Christina and Dr. Neria. Thank you.
Hello. I always get so nervous at that part that it's not gonna work out, but we made it. Thank you everyone for joining us tonight. This is really an honor. Dr. Yuval Neria is a professor of clinical psychology at Columbia University, Departments of Psychiatry and Epidemiology, and director of trauma and Ptsd at the New York State Psychiatric Institute. He was injured in the 1973 Yom Kippur War and was awarded the Medal of Valor. His war experiences have influenced his scientific work. His research has focused on the mental health consequences of exposure to extreme traumatic events, with a particular focus on war veterans and survivors of disasters and terrorism. He has been involved in the development of novel treatment modalities for traumatized populations with PTSD. I've been looking at some of the research he's been involved with, and it covers psychologically distressed women displaced by conflict, the mental health consequences of 9/11, especially looking at it in the context of loss and moral injury. And he's coming to us tonight from New York, where he's been very busy these last weeks. So please, thank you, Dr. Neria, for joining us.
Thank you for having me.
We have a wonderfully engaged audience that always has wonderful questions. I've been getting them all week by email. For those of you who haven't been emailing me, you know the drill. Put your questions into the chat box at the bottom. I would suggest not making them too long because I won't be able to read them without taking too much time. And please try and make sure that they are in the form of a question. I've been thinking about where to start tonight. We talked in mid-April and we were really talking about the many unknowns of the mental health consequences of COVID. And then I look at where we are tonight and I think we have a responsibility to start somewhere else. And I wanted to talk, as we begin, I wanted to talk about structural racism and the anger and frustration and grief we're seeing in the streets of the United States and also here in Calgary and many places around the world. How does structural racism affect mental health? What do we know about that?
So good evening, Christina and everybody, and thank you for inviting me. It's an exciting opportunity to converse about kind of key issues. I mean, those are difficult days here in the US and perhaps everywhere. And I would like to first acknowledge that any discussion that we have today, and hopefully it will be successful. I still believe that we are facing kind of waves of extreme circumstances, extreme adversities. You know, the underlying causes of the demonstrations now in New York and around the world, including Canada, are not completely clear, but definitely long history of oppression and suppression and racism, especially towards Black communities, but not only. We have seen systemic racism towards minorities in the US forever. Japanese, you know, during Second World War, and Chinese minorities, and Blacks, of course, forever, and Jews and Catholics and almost everybody. When at certain point in history have been seen as minority, was subjected to racism, and I think the racism is we are programmed, as you know, biologically to be fearful of whoever and whatever looks different from us, right? So if you go to Africa, to some places that only few white people are traveling, you easily notice how as a white person you became a target for racism and a target for suspicion and also curiosity, certainly, but being different, whether it's especially with regarding to the color of skin, was always you know, a reason for aggression, violence, slavery, whatever. So I think that as psychologists, we have yet to understand racism, and we have yet to find solution for it.
Do you see, and are you concerned about a difference in the way people are treated because of race and ethnicity?
Absolutely. I mean, you know, being an African American, or is put you on risk for almost any medical mental health condition. You're more likely to be imprisoned. You're more likely to be killed. You are certainly kind of inferior in terms of how society run its business. Segregation is still well and alive in certain places, not formally perhaps, but real estate wise for sure, right? I mean, so I don't think we made a lot of progress since Martin Luther King days. I heard Obama today, and Obama was slightly optimistic in the way, I mean, the way he thought about it is that, the situation is awful, but at least, the response, the public response to police brutality is so energized and wide and powerful, that there is at least a promise in the way the public react or now. I mean, the danger, of course, is first of all, being optimistic or having a positive message, is important, especially when it comes from Obama himself, the first American president who has African American roots. But the problem is that, that especially in America, the topic is so divisive that, as strong is the reaction on the left side of the political map, what you see in terms of how police forces react to demonstrators, how right-wing politicians engage in the public discourse, and what you see is, two camps that fight each other in a very extreme way.
I want to follow up on what you said about Obama's optimism. I feel like he does present himself and talks always with an element of optimism and
I agree, yeah.
hope.
Mm-hmm.
How important is that? I think, how important is that in terms of resiliency and mental health, to looking at your situation and finding some optimism in it?
I frankly don't think it matters too much on the mental health side. I think it matters a lot on the political side and on issues like, social mobility and striving for equality, public response, journalism, and see how journalists are attacked, systematically in the last couple of days. So I mean, so hearing Obama's insights really, and almost like an historical perspective, I think it's very, very important. I don't know whether it has an effect on the individual mental health at all. And I think once we are, as human beings, start to suffer from kind of emotional reactions, mental health problems, I think it's this deserve, more than, a positive or optimistic leader, I mean, a little bit of a different attention, at least.
Let's talk about where we are with the mental health of the planet. It's no small task, but when we first spoke, we had this conversation that there are just so many unknowns. Whether this even fits into any of the models that have been studied before in terms of trauma. Is it more like a flu, or is it more like a natural disaster? And so people keep using the word unprecedented to describe COVID. In terms of what you expect to see of the mental health burden, is this unprecedented?
Oh, yeah. I think it's definitely kind of uncharted territory for many of us who are interested to study trauma and the mental health consequences of trauma. And there is, if you think about it, from a research perspective, every trauma, psychological trauma, entails danger or risk or threat to life, threat to physical integrity, and whether it's sexual assault or war trauma, or disaster trauma, flood, nuclear disaster, fire. The COVID is a very weird type of trauma, and it's not easy to even start to compare to what our brain is used to see as a threat. We are, as human beings, as a species, we are excellent detectors of fearful threats. We are, some of us are better than others, but in general, we are easily fearful, which get us to defend ourselves or run away, or do something about what's going on, or sometimes not, because we are unable to. But we are programmed brain-wise to detect danger, to quantify it, if our brain is working properly, and to react to it. We have an entire mechanism to do that. This is not working now with the COVID. The COVID is really tricking us, again and again. And you can see, if you look around you, and I'm sure the audience can relate to it, if you look around you and see how people that behave, most of them don't behave fearfully. There is definitely threat to life, or we have been under threat to life. But because this, threat was not really identified in location and time, there was no real boundaries of where the virus is and how the virus can attack us, and who is vulnerable and who is not, and what is the pace of the spread, and what should we do in order to defend ourselves. Nothing is clear. Now, there are tons of researchers, especially on the medical side, that kind of trying to understand now, the behavior of the virus, and the risks that it's posed on humanity. But nevertheless, psychologically, we are, it's kicked us, out of the playing field. So so many of us are kind of slightly depressed. We all have been very anxious initially, and now we are a little bit depressed, fatigued, tired, perhaps a little bit numb. Certainly, displaying all sorts of kind of bodily aches. This is what I hear from people around me. People are tired, and this is really going on with ongoing stress, exposure to stress. Now, the research is not set up really to deal with it, and the research of trauma, or and the research of therapeutics is not really set up to deal with it. So we are, trying to find solutions as we go, and it's not easy, frankly.
So much of your work looks at PTSD, and how do we know not everyone who's exposed to a trauma develops PTSD? So I guess I'll ask you to give our audience an explanation of what PTSD is, because I think there's a lot of confusion about that. And then what puts people at risk for it?
Yeah, no, I can try. And what you ask is really a course of at least 1 year, but let me try to do it in 3 sentences.
Thank you.
Which I'm sure will not be successful, but let's try. But anyway, a couple of principles. I mean, trauma is very common. I mean, most of us, if not all of us, are exposed to trauma, whether within relationships, car accidents, wars, immigration, you name it. I mean, trauma is very, very common. Now, most of us, or most of human beings, are pretty resilient, meaning that they are not going to develop PTSD, and that they are not going to develop other trauma-related disorders, such as depression, other anxiety disorders, etc. So the name of the game really is resilience, right? Most of us are resilient human beings. This is not suggesting that we don't feel or we don't remember. We will remember almost, most extreme negative things that happen to us. Most of us, by the way, are not great to remember positive things in their lives, but negative things, we remember them, right? We can remember, the teacher in high school who humiliated us, and we'll never forget that. Or we remember car accidents, or whether we fell off a horse, right, or whatever. Now, so then you can ask yourself, so what's going on, right? So what's going on is that a certain proportion, a small proportion of human beings will develop trauma-related mental health problems at the aftermath of exposure to trauma, whether it will be immediately or even during trauma, if trauma is ongoing. Some of us, if trauma is ongoing, let's say sexual abuse over time, or imprisonment, or being in a refugee camp, for a long time, people can break down during the experience. But most people are holding up pretty well during the experience, and something at the end, makes them very vulnerable to start develop symptoms. And the first wave of symptoms is very much expected, even among resilient people. Stress, nightmares, difficult to sleep, difficult to concentrate, avoiding people, or avoiding thinking about the traumatic experience, trying to shut down anxiety and fear. Those set of symptoms are all becoming PTSD-like symptoms if they are lingering and ongoing and are not, diminished by themselves. So what I would like to say, in short, that trauma may bring all of us to develop all sorts of kind of early symptoms, especially affecting how we think, how we feel, whether we sleep, whether we have energy, and we expect those symptoms to kind of be alleviated, and if not, and if they are lingering beyond 3, 4 weeks, 5 weeks, they can become PTSD or full-blown PTSD. And full-blown PTSD is a pretty debilitating disorder that can show up in a lot of anxiety and depression. Suicidal ideation is very common. People are really tired and fatigued and don't sleep well and don't think well, and they need treatment.
So I always feel like you should never ask 2 questions in one, and I know that especially when you're speaking to psychiatrists and psychologists. But I am gonna do that to you, and I'm gonna. Are we in conditions? Is COVID a condition that you think will trigger or start a lot of PTSD for people? And the second half of that is, if so, how do we make ourselves resilient? Are there things we can do?
Yeah, again, you know, that's the second year of the course. But Christina, I you know, Frank, and trying to be, you know, always honest with people that, you know, ask me questions that I don't know the answer. So I really, I'm not sure whether I can give you an informed answer to your question, especially with regard to how traumatic COVID is, right? So COVID is a bunch of stressors for sure, right? As I described, you know, you don't have a vaccine, you don't have therapeutics, you don't know where the virus is, you don't know, you are in social isolation, you don't have enough social support, you don't exercise, you don't sleep, you can't go to the office, you may be laid off of your job, you have financial problems, and now you have, you know, terrible events around you that concerning brutality and aggression and kind of bringing, you know, on top of COVID, really traumatic memories, traumatic history. And so there is really a bunch of highly stressful factors here. For some, this is very traumatic. For example, medical teams, right? Frontline medical teams, doctors, nurses, first responders, you know, police, fire department, you know, they were all exposed to death, you know, exposed to really horrifying aspects of the COVID. This is certainly a trauma. This, you know, group of people is certainly at high risk to develop PTSD. Right? The other group that is certainly at risk to develop PTSD are people who are low income, blue collar, and, you know, bus drivers, train drivers, people who are working for us, you know, in public sectors, and people who are under tremendous financial concerns. And those people are always, and minorities, you know, such as in the US, Hispanics, you know, African Americans. This group is always the first to pay the price, whether mentally or medically. You know, the proportion of deaths within this group was higher. The proportion of mental health problems will be higher, and this is based on what we have seen after 9/11, after Katrina, after almost every, you know, kind of big adversity or big disasters, you know, the first group to show vulnerability in terms of mental health problems are people who are less advantaged. You know, they are the poor, the immigrant, the older, the uninsured, and the minorities. This is a group that's paying the highest price, always, always, always. And especially in America, where, you know, where medical insurance is not guaranteed or certain for this group, the situation is much worse, right? So, you know, I'm in upstate New York now, and at our house here, and we are so fortunate because we have a lot of kind of immigrant Mexicans, especially, but not only, who are helping us and helping everybody around. And some of them are wonderful, wonderful people, and none have citizenship, none have green cards. I mean, the kids have, but the parents don't. And they don't have medical insurance, and they don't have a guaranteed income. And they are even, you know, and they are never benefited by anything that we put out in terms of mental health services. They are not eligible for it. They don't seek it. They are not benefited by it. So what I'm saying is that that any disaster, and the COVID is included, exposing weaknesses, kind of systemic weaknesses within our society that are directly related to mental health problems, really.
Your question just reminded me of something that a physician had said to me earlier this week, and we were talking about people who struggle with a feeling of hopelessness. And this is talking about people who do have access to mental health services. But what do you say to someone who's feeling hopeless in the aftermath of a trauma? To make them feel that there is hope, but without diminishing the importance of what they've been through.
Yeah. So hopeless is a symptom. This is a symptom of depression, and should be, you know, once you know, we have an opportunity, and we should frame it as a symptom. So this is not, this is helpful for anybody, or maybe helpful for anybody who feels that, in order to know that there is a name for it. It's part of a syndrome, and the syndrome can be treated. Depression can be treated, you know, with you know, psychotherapy or medication, or a combination of psychotherapy and medication. And if you have, you know, I know that in Canada, luckily, you know, you have better access to mental health services, but also in the US, you know, it's important to know that both depression and PTSD are treatable. They are treatment for depression, and if the treatment is not provided in a timely fashion, you know, hopelessness can lead to suicide. I mean, most of the studies on suicide suggest that there are three kind of building blocks for suicide. One is a feeling of hopelessness, meaning, you know, there is nothing in the world that really is worthwhile, and I am such a failure, I will never make it. I will never get out of that. You know, I'm stuck, and there is nobody there to help me. And so it's about me, it's about other people, and it's about the world. And the world is in an awful shape. There is no reason to live in this place. And by the way, you know, the difference between depressed person a normal person is not about so much about, the assessment of what's going on in the world right now. The world really is, we see the struggle, right? I mean, and so there is COVID, there is racism, there is police brutality, there is leadership is sucks, and et cetera, et cetera. The problem with depression is really about the interpretation, right? And this is related to what you asked, I think second question about optimism. Because when, the difference between a person who is depressed now in these days, or seriously depressed, and a person that is mildly depressed or normally depressed, and I think all of us are kind of mildly depressed those days. The person who is acutely depressed or very much depressed feels that there is no way we are going to get out of it. I mean, it's so dark, it's so awful. There is a total collapse in so many ways, right? So there is no reason to be optimistic at all. And the person who is kind of mildly or normally depressed is a person who say, you know what, it's awful now, it's terrible, but listen, there are elections in November, perhaps the good people will win, and I'll see my children next week, and we'll go to a restaurant. So these glimpses of hopes are really, really suggesting that, kind of demonstrating the difference between somebody who needs help, who don't have those, glimpses of hope, as compared to somebody who still has them and perhaps can, survive this COVID and what's going on around us.
If we were to look at this at a societal level, considering the number of people, as we were talking about, who can't access mental health services, what is the consequence to a society if trauma is not reconciled and treated, and it's a society with a lot of trauma?
Right. So again, it's hard to predict whether we are going to see a mental health pandemic that will really come on us so big and so fast that as a society we won't have the right structures, tools, capacities really to cope with it. And we can, from what I see, studies that have been done and in the last couple of months, as there is a rise in depression, anxiety, and to levels that are yet to be seen before at all. There is a 35% jump in prescription of psychiatric medications, especially for anxiety. And I think this is kind of an underestimate. Sorry, there are studies suggesting that 50% of the medical teams, frontline medical teams, have full-blown depression. And there are already reports on higher risk of suicide. Again, there are medical there are people from the medical profession that already committed suicide. There is one actually here in New York that was working at Columbia University Medical Center, was head of emergency department at one of the hospitals. Very sad case that was published in the Times a couple of weeks ago. And so the signs, there are signs or early signs that we are going to face, great high demand and for service, for mental health service, and I don't think we have the right answers for that.
Are there things that governments, institutions should be doing, like policies that should be implemented now that can improve the psychological health of citizens?
Yeah, if it's not too late already, but the answer is of course yes. I mean, I think we should move more forcefully to developing effective online mental health interventions for the public. And I don't think that the old models of face-to-face, office-based visits in a psychoanalyst office in the Upper East Side is gonna work for COVID patients at all. I think we should prepare ourselves to provide briefer kind of in a large scale trauma focused, grief focused interventions to the public. I think insurance companies should cover this and develop regulations to cover this. I think we need to educate the public about a number of risks. Public need to be psychoeducate to know how to self-monitor themselves, especially the same as they did for other COVID symptoms, whether it's coughing or fever or whatever. It's easy to self-monitor PTSD symptoms, depression symptoms.
What are the things we should be looking for as
we need to look at sleep, whether we sleep well, or how bad we sleep, whether we can have enough sleep. And we should look at whether we can concentrate. We should look at how anxious we are. We should look at our level of pessimism that we discussed before. And if we feel suicidal, we need to know that, and we need to involve other people in that. There are excellent 1-800 service lines for people with suicide ideation, and especially for people who are moving from suicide ideation to planning suicide. And there is a lot of research on that. There is really, people should be careful with consumption of drugs and alcohols, and control medications, right? If people are feeling that they become addicted to alcohols and drugs, they should do something about it. And it's so we should educate people about the importance of physical exercise, high importance of physical exercise, daily physical exercise. And we should really speak about it a lot. We should limit ourselves how much we are exposed to social media. Being with our eyes into the computer all day long or smartphone is really bad, mental health wise. And there are a number of studies showing it, including COVID studies. And we should make mental health interventions available, accessible, and simpler to understand, and get the public engaged in it. And I think without it, I'm quite, pessimistic about whether we can sustain this wave.
I have a question that I should have asked. It's been here on my screen for a while.
Okay.
I'm a survivor of the sunken cruise ship Costa Concordia. My husband and I had a traumatic experience, yet grateful survivors. I've been speaking and sharing our experience and my journey in recovery, or thought I was recovery, until the onset of the pandemic. Within hours and days of the global devastation, I noticed a similarity in the trauma. I've had to deal with the reality of PTSD being a condition that will always remain an underlying medical sensation that will be triggered at any given moment. Does your research indicate that one can be cured, or does one have to continue learning coping mechanisms?
No, I do think that people can largely recover from PTSD. Not everybody, but a lot of people. And I've done a lot of brain studies among people who went into treatment, before and after treatment, and using MRI, fMRI, and I came to understand and to appreciate really the potency of good treatment, trauma-focused treatment. So I really recommend the audience, and especially the person who asked the question, that if there is a relapse, I think this is what she or he experienced right now, a relapse of PTSD symptoms from a previous trauma, coming back. There are treatments for PTSD. For example, prolonged exposure is an effective treatment. Interpersonal therapy is an effective treatment for PTSD. So I wouldn't really delay it. I don't think, delaying treatment or ignoring treatment or thinking that, treatment can be, is not going to help is a good way to think about it. I think there is enough evidence, suggesting that when treatment is provided in a timely fashion and it's really focused on the trauma, it may be extremely helpful.
Can you tell us what prolonged exposure treatment is?
Sure. So, there is quite a bit of research about which treatments are effective for PTSD. One of the most effective treatments is prolonged exposure. The idea is that the patient and the therapist are discovering the most impactful traumas in the life of the patient. And once they identify, a single trauma, or sometimes more than one, they are starting to process, the memory of the trauma in a very structured way, again and again, until the trauma is not anxiety provoking anymore, not experienced as fearful and dangerous, and it's this change is happening pretty fast, in 3-4 weeks of intense discussion and kind of memorizing the trauma. There is always a chance for a great improvement. The patient is asked not only to talk about the trauma with his therapist every session, it's about 10 or 12 sessions, 3 months only. It's a brief therapy, but also to listen to the recorded account of the trauma as a patient describe it to the therapist daily. And in addition to that, there is a series of exercises that involves dealing with avoidances. So most PTSD patients avoid thinking about the trauma, avoid places or human beings that reminding of the trauma, the treatment really is important because the patient is encouraged to confront those avoidances gradually in a way that enables the patient really to gain control over things that were very anxiety provoking for him or for her. So in short, prolonged exposure is not about running away from the trauma or hiding from the trauma or trying not to think about the trauma. It's almost the opposite. It's an opportunity to process really the fearful experiences again and again until they are really done. And what we see in the brain is really a big change. You know, for example, you know, we look at, there is one brain region, a tiny brain region called amygdala, right? And the amygdala is responsible for detecting fearful threats and also responding to them, right?
Right.
And amygdala activity among people with PTSD is very, very high. The level of activation is very high. In the beginning of the treatment, once treatment is going and successful, we can see amygdala activation going kind of normalized and regaining, you know, normal levels. And there is a tremendous effect on psychosomatics. People who had migraines for forever, you know, stop having migraines, and people have, you know, really better life, better relationships because of a good treatment. So I really recommend it, especially among people who have access to such treatment.
And I had two questions about the sort of versions of fear and like anticipatory trauma. And one came from a parent and one came from a healthcare worker. Here in Calgary, there was a lot of fear about what was going to happen in our hospitals. And we did not see an enormous surge of patients, but there was a lot of fear when people first started coming in with COVID. And so I guess it's a two-part question. Like, does that anticipation of something really bad, does that have like a lasting mental health effect?
I don't think so. So, I mean, again, you know, fear is a normal reaction to fearful conditions. It's expected. People who don't have fear or don't feel fear are largely not equipped well to deal with danger, with adversities. And I think what your I think the question relates to the possibilities that fear will be lasting or enduring, you know, above and beyond, you know, the initial phase when it's functional and helpful, right?
Yeah.
So that's really the difference between fear and anxiety, right? When fear transforms to anxiety, you know, where there is a large amount of concerns and worries, and people can't sleep, and people are disturbed, and people are not functional. Yeah, this is happening from time to time, and again, you know, there is great treatments for anxiety or generalized anxiety disorder, right? It's another kind of psychiatric term to describe, you know, kind of a lingering fear into anxiety, right? Or excessive anxiety. And again, there is treatment for it. SSRIs, you know, a host of psychiatric medications can be helpful. There are some, you know, other drugs that can be helpful, and certainly cognitive behavioral treatment can be helpful in anxiety.
Um, what about moral injury arising
Yeah.
from the, maybe you could tell us a little bit about what moral injury is and whether you think that it will be a problem because of the pandemic.
Right. So, so moral injury, we are seeing it especially among soldiers, among veterans, who have been witnessed immoral behaviors or have been involved as perpetrators in immoral behaviors. So somebody who has killed, civilians, children, women, or somebody who has witnessed other people killing civilians or conducting violent offenses towards civilians. So a lot of veterans are coming back to civilian life with where they are morally injurious, right? They feel guilty, they feel ashamed, they feel that they didn't stop, aggression, or they were part of unjustified aggression, and whether they have PTSD or not. Some of them have in addition to that PTSD, and some of them don't. Some of them live with guilt forever. Think about, kids who have been, kind of, witnessing, sexual abuse towards their brothers or sisters, right? And they didn't say anything or were not able to stop it or to avoid it or bring a parent to do something. So those are morally injurious experiences, and they can change lives of human beings, sometimes for many, many, many years, unless there is an opportunity really to discuss those things and to work with them. I think COVID present another circumstances for a host of morally injurious events. I mean, think about doctors, young doctors, and others who have been under overwhelming conditions in emergency departments or ICU departments, and had to make decisions about who lives and who dies, who will be, treated with a ventilator, and who will be not treated with ventilator, who will get off of a ventilator prematurely or not, right? Those are potentially morally injurious events that we will hear about them for many years, I'm sure, in forms of books, movies, and treatment sessions, and first responders who I heard got instructions not to bring people to hospitals and let them die in their tracks, and not being resuscitated. I mean, there are awful stories that happened during COVID that are kind of trying to come to the surface now.
For you as a psychologist, do you see, in terms of the burden of moral injury ahead and the work ahead for you, how does it compare to 9/11 and other things in your career?
So I don't know yet about COVID. I mean, we have a treatment center at Columbia University Medical Center for veterans and their family members. So, which my team is has a opportunity to establish and run it for the last 4 years. We see a lot of moral injury, and from my work with young doctors at the hospital in the last 2 months, I still do that. I hear quite a bit about guilt, about anger towards senior professionals, sometimes. And we can see that also in the press quite a bit, right? So, I mean, I think again, you are so lucky that in Calgary you didn't have this intense, spread of infection as we had in New York. But in New York we had, in certain points, 700, 800, 900 deaths every night around the hospitals in Manhattan, with tracks, outside of hospitals that served as a temporary graves, and with people dying without family members around them, and people dying in the hall even before they got into emergency rooms, and people dying everywhere. So there is interesting research trying to uncover why certain areas didn't show high levels of spread versus other areas that have showed. Certainly New York was kind of high impact area for COVID, and we got so many health professionals that contracted the virus and hospitalized. So there were, so when you have this intense, semi-battlefield type of event where people are dying in scores, right? So think about it. I mean, I don't think we are capable as human beings to process it really fully, and in terms of finding the right balance. I mean, what to do with those memories? I mean, what do we do with things that you see that are so intense and so frightening and so much morally kind of conflicted, right? What do you do with them? And it's changed the lives of people forever, and whether they have PTSD or depression or not. And I think there are generations of young kids, first responders, young doctors, young nurses, and that their lives are changed forever. Yeah.
Well, I've gone over time. I have more questions here, but I'm going to call Michal onto the screen here. Thank you. You've been so generous with your time. Thank you so much, Dr. Naya. I know you had a very long day. Welcome back, Michal.
Thank you for this. Sorry, I just went to lock, by the way, ethics. I just went to lock my 2.5-year-old outside so she doesn't interrupt my concluding remarks. But she's with her dad, and it's warm. So thank you again. Thank you, Dr. Neria, for staying up so late. Thank you, Christina, for this great conversation. Thank you from the bottom of my heart to Sean Lindsay, the coordinator for the Institute for the Humanities, for doing all the technical work and making this happen. The Calgary Institute for the Humanities at the University of Calgary has been such a keen sponsor for this event, and we couldn't have done it without them. So I wish to thank them again, and in particular, Dr. Jim Ellis and Dr. Justin Weinhardt. This conversation concludes our digital series. So thank you all for partaking, listening, weighing in, and thank you for the gift of your time.
Thank you. Thank you. And good night, everybody.
Good night. Good night, Yuval.